Patricia, you're doing a quick opening, right? And sending it to me.
Yep. Okay, we are live. Good morning. Welcome all attendees to the COVID-19 pandemic in 2021 webinar symposium. We are pleased to bring you this event this morning, hosted by the Association for Healthcare Risk Management of New York and Empro Insurance. We have a great lineup of expert panelists that you'll be hearing from today, and our program will be moderated by Dylan Braverman. A few reminders for the attendees that the program will be muted during the entire webinar. You can submit questions at to the dialog box on your screen, but if you are attending by telephone, you can email a question to the email address cited here on the screen, ahrmny@gmail.com. We have submitted this webinar symposium to 3 accrediting agencies, and the program is being reviewed for CME, CPHRM, and CLE credits. And those certificates will be sent to attendees pending approval of the program. We are also recording the webinar, and the recording will be made available after today. And now I will turn the meeting over to AHRMNY's President, Michael Brendel.
Good morning, everyone. On behalf of the Association of Healthcare Risk Management of New York, I want to thank everyone for attending this morning's webinar. I want to thank our past president, Dylan Braverman, President-elect Rob Marshall, and the entire Education Committee for putting together today's webinar. And of course, I want to thank our wonderful speakers for taking time out of their very busy schedules to be with us today. I also want to thank Empro for sponsoring this morning's event. And with that, it is my pleasure to introduce Dylan Braverman. Dylan is the partner at Vigorito Barker and works with Chuck Bayless in the COVID litigation department. So with that, I'm going to turn this over to Dylan.
Thanks, Mike. Hi, everybody. Thank you very much for joining us. My role today is, frankly, going to have the pleasure to introduce 4 of the most learned experts on the topic that we're going to be discussing today, COVID-19, especially in our area in New York and New Jersey. You'll find out as I introduce them. You're going to hear me say my favorite consulting doctor a lot, because frankly, I speak to all 4 of these doctors whenever I have pertinent medical issues on my legal cases, and they've all distinguished themselves in examining the cases and helping me defend my clients. So I'll start first with Dial Hewitt. He is currently the Medical Director, Division of Disease Control, Chief of Tuberculosis Services at the Westchester Department of Health. Dr. Hewitt received his medical degree from the University of Wisconsin-Madison and is board certified in internal medicine and in the subspecialty of infectious diseases. He served an internal medicine internship and residency at Harlem Hospital Center, Columbia University College of Physicians and Surgeons in New York City. He was also selected to serve an additional year as chief medical resident in internal medicine at Harlem Hospital Center. Following internal medicine training, Dr. Hewitt went on to complete a 2-year clinical and research fellowship in infectious diseases at Montefiore and Albert Einstein affiliated hospitals in the Bronx. Dr. Hewitt served as the chief of infectious disease division at Lincoln Medical and Mental Health Center in the Bronx and associate professor of clinical medicine for 9 years prior to joining the pharmaceutical industry in 1996. During that time until 2014, he served as an infectious disease consultant at Lawrence Hospital Center in Bronxville, New York. Dr. Hewitt is a fellow of the American College of Physicians, the Infectious Disease Society of America, and the New York Academy of Medicine. He currently serves as a consultant in infectious disease and chair of infectious disease control at Calvary Hospital in the Bronx. He is also an adjunct associate professor of immunology and microbiology at the New York Medical College in Valhalla, New York. You guys will find out for a second, if you haven't heard Dr. Hewitt speak, he's fantastic, and you'll find out why he's one of the most sought after infectious disease experts in our field. Next, I have the pleasure of introducing Dr. Patricia Whitley Williams. She is a professor of pediatrics. She's chief of the Division of Pediatric Allergy, Immunology, and Infectious Diseases, and an associate dean for inclusion and diversity at Rutgers Robert Wood Johnson's Medical School. She's a native of Boston. She received her Bachelor's of Science degree in biology from Simmons College in Boston and her medical degree from Johns Hopkins University School of Medicine. She completed her pediatric residency at Children's Hospital Medical Center in Cincinnati and her fellowship training in pediatric infectious diseases at Boston City University, Boston University School of Medicine. She served on the faculty of Boston University School of Medicine and Morehouse School of Medicine in Atlanta, Georgia, before joining the faculty at Rutgers, formerly known as the University of Medicine and Dentistry of New Jersey. She is board certified in pediatrics and pediatric infectious diseases and is a fellow of the American Academy of Pediatrics and a member of the Alpha Omega Alpha Honor Society, Medical Society. She has published articles in several book chapters, served on national grant review committees, is recipient of many awards, and has mentored many young pediatricians, residents, and medical students. She is a member of the Infectious Disease Society of America, the Pediatric Infectious Disease Society, the American Academy of Pediatrics, and the National Medical Association. She serves on national committees, including the National Foundation of Infectious Diseases, president, the National Medical Association's liaison member of the Advisory Committee on Immunization Practices at the Centers for Disease Control and Prevention, member of the Governance Review Task Force, and the National Board of Medical Examiners. She's a member of the New Jersey Department of Health Professional Advisory Committee and the New Jersey Department of Health's COVID-19 Professional Advisory Committee. She's an active member of the Central New Jersey Alumni Chapter of Delta Sigma Theta Sorority Incorporated. Her research interests include HIV/AIDS in women and children, as well as children and adolescent immunizations. I'd say that Dr. Whitley Williams has been busy. Next up, we have Dr. Cudjoe. Dr. Cudjoe is an internal medicine and geriatric medicine physician and associate professor of medicine at Johns Hopkins School of Medicine. He's also a major in the United States Army Medical Corps. Dr. Cudjoe is summa cum laude graduate of Hampton University. Thereafter, he completed his medical degree at Rutgers Robert Wood Johnson Medical School and his master's in public health at Harvard School of Public Health. He then completed residency in internal medicine at Howard University Hospital and his fellowship in geriatric medicine and gerontology at Johns Hopkins School of Medicine. He is board certified in geriatrics and internal medicine. He continues to care for patients in their home through a home-based medical practice in inpatient clinical settings and long-term care. He has been active prior to and during the coronavirus pandemic, caring for adults and older adults in outpatient and inpatient settings. Additionally, while mobilized with the U.S. Army Urban Augmentation Task Force, he helped establish and care for COVID-19 Field Hospital COVID-19 Transition and Care Unit and part of the COVID-19 surveillance and telemedicine team. And you'll find out in a second why he is one of the most sought after experts in the field of geriatrics. Finally, last but definitely not least, Dr. Kelvin A.J. Chone is currently board certified emergency physician at St. Barnabas Medical Center in Livingston, New Jersey. Prior to this, he worked at a community hospital in the DC metro area. He's born and raised in New Jersey. He attended Rutgers University for his undergraduate studies. He was accepted to the Access Med program and completed medical school at UMD, New Jersey, Robert Wood Johnson Medical School. During this time, he also completed a dual degree program and graduated with an MBA from Rutgers Business School. He attended University of Chicago for his residency in emergency medicine. Here, he held the role of co-chief of the International Physician Escort Program with AXA Assistance. He also completed a rotation at the Kumfo Anoi Teaching Hospital in Ghana, home to the first emergency medicine residency in the country. He currently lives in Maplewood, New Jersey with his wife and 2 children. And without any further ado, I'm going to turn the mic over to our first speaker of the day. And are you ready to do the slides, Keisha?
Yes.
All right.
Yes. Good morning, and thanks for that introduction. This is just an overview for all of you for the agenda for today, and just to give you some high points as we get into our actual program. We're certainly happy to be here. One of the things we want to do is to try to dispel a lot of the myths that may exist around COVID-19. We know that this is a very experienced audience that we have here today, but we do know that sometimes myths can actually creep in, and we want to try to make sure that we are talking about the facts. Those of you who have been around for as long as I have are familiar with the gentleman on the right-hand side of the slide, Sergeant Joe Friday from a program called Dragnet. And he was always asking for just the facts. He didn't want hearsay. And so today we're going to be loading you with some of the important facts. And so as we get into our program, one of the first facts that we have to keep in mind is that the US, as President Biden said last week, has 4% of the world's population. We have 25% of the COVID cases and 20% of the COVID deaths. So we have a lot of work that we have to do. On average, as of last week, about 4,000 people died per day. That was last week. Now think about this and put it into perspective. This is more people than died in the World Trade Center disaster on that one single event. We also are going to be giving you a little bit of information on a hot topic, the new variant strains. These strains are more easily transmissible and may give rise to future surges, as Dr. Fauci and other experts have told us. Now, one of the other things which is a fact is that COVID can be serious in infants and in children. It's not just a mild disease. Infection and death are significantly higher, more likely to occur in African Americans and members of our Latinx populations. And despite stringent precautions, COVID can spread rapidly in assisted living and long-term care facilities, and also in other congregate settings. And the last fact is that unless we can reach herd immunity, which now is going to be between 70 and 80%, this pandemic is going to continue. And so this is going to take a real team effort on the part of all of us. We can't have anyone on the bench. Everyone who has received the vaccine and is eligible to receive the vaccine can potentially act as an ambassador to bring other people into the fold so that they will accept this vaccine as well. Go to the next slide. This is just going to be a listing then of our program for today. We're going to start with challenges in the emergency department and urgent care facilities by Dr. Chum. And then that's going to be followed by Dr. Patricia Whitley Williams. She's going to be talking about coronavirus infections, specifically COVID-19 in children. We then are going to go to Dr. Cujo, who is going to be talking about the clinical manifestations of COVID-19 in our older populations. And then I am going to be coming back and we're going to be talking about some of the recent developments in vaccines, how the vaccine programs are going, and some features about the vaccines that are currently available. So with that, I'm going to turn the program over to our first speaker, Dr. Kelvin A.J. Chum.
Thanks so much, Dr. Hewlett. So we can go to the next slide. So as mentioned, my name is Dr. A.J. Chum. I am a board certified emergency physician in Northern New Jersey. I'd like to thank Mr. Braverman and his associates and all the co-sponsors for inviting us to speak today. So I'm just going to touch a little bit on the approach to COVID patients in the acute care setting. So the emergency room as well as urgent care setting. So we can go to the next slide. Some of my takeaway points that I'm going to discuss is how we go through screening guidelines and tools to diagnose COVID patients in the ER. We're going to touch on the current management and some of the medications that we currently use for our COVID patients. And last, we'll talk about disposition follow-up considerations. Throughout my slides, I'll point out challenges that we see in the emergency department. It's important to note that, COVID-19 is a dynamic disease. We're still learning a lot about it. And so some of those challenges we've been able to face and some we're still trying to tackle. So next slide, please. So first things first, when a patient walks into the emergency department, how do we know if that patient has COVID or not? We really don't. And so it's important for us as staff to make sure that we're protecting ourselves and then we're protecting others. And so myself, my colleagues, when we see a patient, regardless if we're concerned about COVID or not, we're wearing an N95 mask when we actually go and see that patient. It's important for us to have good screening questions as well too. Fever is not the only presenting symptom that a patient may have when it comes to coronavirus. Early in the pandemic, the only way that we were allowed to test for patients, test for COVID, is if they had a fever and if they recently traveled from mainland China. And we know now that's null and void now that there's community spread. And so initially in the disease, fever is really present in less than half of patients. It will progress, and up to 90% of patients will end up having a fever, but the initial presentation may not have a fever. And so it's important that we ask additional questions. So typical viral questions: shortness of breath, body aches, nausea, vomit, and diarrhea, loss of sense of smell, loss of sense of taste seem to be unique things to coronavirus. And so it's important that we ask those questions. And then next we'll look at the vital signs. Is their blood pressure low? Do they have a high heart rate? And within the vital signs, the pulse ox is really going to help us in terms of guiding who's sick and not sick. And so this is important because one of the challenges that we see in the emergency department is surge capacity, and sometimes that waiting room is very full. And so if a patient has a pulse ox that's less than 90%, they're going to go into a negative pressure room right away. If a patient has normal oxygenation, that patient may be able to wait in the waiting room, of course, socially distant, have their mask on. Sometimes in our ER, we'll ask patients to wait outside if weather permits, or even in their car until we have room to bring them in. We're also looking at specific labs, and so we're going to send off labs to look at inflammatory markers. We'll get a chest X-ray on these patients, a CAT scan if we're at high concern for pulmonary embolism or any complications that we may think could be contributing to the shortness of breath. But it's important to note that when we get these images, we're also exposing the staff to COVID as well too. So we really only want to order things if we think it's really going to change our management. So when we do chest X-rays, we're actually going to do portable films where the X-ray tech actually comes into the room. When we do a CAT scan, we're only going to use one CAT scan machine in the hospital, and we're going to clean that machine just so that we decrease the amount of spread within the hospital as well too. In terms of labs, some of the labs are all, of course, inflammatory markers, but then the testing, PCR versus antigen. It's important to make sure that not only we have fast testing, but we also have accurate testing, right? Throughput is one of the things that we look at in the emergency department setting. And so when it comes to testing, we need a rapid test because all the patients who are being admitted, they may go to a COVID floor versus a non-COVID floor. And so if we have a rapid test, we can easily get that answer and be able to move patients through the emergency department. Antigen testing is something to keep in mind in places such as urgent care where budget might be a little bit lower. It's not as accurate. There is a high false negative rate. And so it's important that you have a fast PCR testing to really get accuracy and rapid results. And then we want to keep in mind our special population. And so these folks are at high risk for having a severe case of COVID. And then if their severity is high, there's also an increased risk of death. And so the elderly, obesity, if you have comorbidities as well too, those are patients that we want to see quickly. We want to triage quickly. We want to diagnose quickly and intervene quickly. Next slide, please. And so once we have that diagnosis of COVID, what are some of those medications that we currently use in the emergency department? So first things first, with any virus, it's supportive care. And so if they have a fever, you want to make sure that we're giving Tylenol or Motrin to decrease that fever. As you know, if they're dehydrated, IV fluids as well. In the emergency department setting, our main concern is that oxygenation. And so do they need supplemental oxygen? We have folks who just need minimal oxygen, and so we'll put them on a nasal cannula. There are folks who may progress and need some more support, and so we may use BiPAP or high flow to provide some positive pressure. And then of course, patients who come in with severe distress, they may need to be intubated. But for the folks that we are intubating and putting on a ventilator, we are also making sure that we are following our precautions. We have our PPE on. We're going to minimize the amount of people that are in a room because we know that these are aerosolation procedures. And so we want to minimize that risk of spreading COVID. And so we're going to make sure that everything is set and prepared when we do those type of procedures. If you are requiring oxygen, then you meet criteria to receive remdesivir, which has been FDA approved. It's an antiviral, so if you can think of it as the Tamiflu for COVID, you will also receive dexamethasone, which is a steroid. For those folks who do not meet requirements of needing oxygen and are in our high risk, so our special population, they're going to meet criteria for the monoclonal antibody. So we think about Regeneron. We also think about bamlanivimab. There's supply limitations with these monoclonal antibodies, and so those are the patients that will receive it if you're in the high risk category and if you've had onset of symptoms within 10 days. And then convalescent plasma, we kind of say for our severe cases, also because of limitation supplies. So some of the challenges here with medications is that medications are now changing. A few months ago, hydroxychloroquine or Plaquenil was what was touted as the medication that we use with COVID patients. And we now know that it's no longer recommended. And in fact, there have been some detrimental effects where patients have come in with cardiac arrhythmias. We're still seeing patients come in who've been diagnosed in their primary care with COVID or in the urgent care who are still being put on hydroxychloroquine and azithromycin. So that's something to definitely keep in mind, that it's important to keep up to date with the medication standards. I do want to make a mention of anti-coagulation. It's been found that, of course, we know that there's some long-term complications and there's also increased risk of clotting disorders, PEs and DVTs. And so we do have patients, if you're being admitted, you are placed on anticoagulation, Lovenox or heparin. If there's a high concern for pulmonary embolism, then we are treating you therapeutically. And my last slide, please. And then I just wanted to touch on disposition and follow-up. And so if you're requiring oxygen, it's pretty clear that you're going to be admitted to the hospital. You'll receive an infectious disease and pulmonary consultation. If you're being discharged home, of course, we want to make sure that these patients not only have good follow-up with a primary care physician, but that they understand strict quarantine and then things to look out for, because we know that things can progress. So we want to make sure they go home with a pulse ox or are able to purchase a pulse ox, and then look out for the signs and symptoms of things reasons to return to the emergency department. So worsening shortness of breath, chest pain, if they notice that their legs are swollen, because they can be at risk for DVT, pulmonary embolism, stroke-like symptoms. Those are the reasons to come back for. I did want to make a mention of the folks that look well, but their oxygenation may be a little bit on the low side, so 88 to 90%. Those are the folks that are kind of hard to decide. Do we bring them in? Do we send them home with close follow-up? And so these may be the folks that are candidates for observation. You may want to keep them for a day to watch them to make sure that their disease doesn't progress. And we also have a program where we can actually send folks home with a home oxygen concentrator. With that, we want to make sure that we have our social worker and case management involved, because we also want to make sure they have the tools necessary to use the machine, and that also they have good follow-up so that they have a telemedicine consultation within 24 to 48 hours to make sure that their disease hasn't progressed and that they're doing well. And then with that, my next slide, I'd like to thank everyone, and then I'll pass it on to Dr. Whitley Williams, who's going to focus on our pediatric population.
Thank you so much for that wonderful presentation. So my task today is to talk to you about COVID-19 in children, and particularly what we call multi-system inflammatory disease. Next slide, please. You heard my disclosure, introduction, that kind introduction. Next slide, please. I have no other disclosures. So as you have heard, children tend not to be as sick as their adult counterparts. And this slide is from the CDC, looking at the reported incidence by age group. And indeed, it is the lowest in children who are under 18 years of age, even lower in children under 4 years of age. So the incidence is only about 1,800 per 100,000 in those young infants and young children, preschoolers, compared to an incidence of 7,000 per 100,000 in people who are older than 85 years of age. So you can see by this graph that children really do have a lower incidence of COVID-19 infection and all types of COVID-19 infections. It is interesting to note that the incidence is actually highest in the 18 to 29-year-olds. And again, these are not always, not all of these are very ill, but it's interesting to notice this is, certainly the younger generation that tends to be out and about. So next slide. And this looks at the seroprevalence. This is actually as a result of using blood or serum samples that were coming from children who either were admitted or were using the laboratory at the University of Mississippi Medical Center. And they were able to test for SARS-CoV-2, which is a virus that causes COVID-19. And these children were all under 18 between May and September of 2020. This data has not been published yet, but I show this because there definitely is a disproportionate involvement of Black and brown children, African-American and Latinx children. And you can see here that even though the numbers are small compared, to national numbers, but they looked at 1,603. And of those, overall 175 were positive, giving a seroprevalence rate of 10.9%. But if you break it down by race ethnicity, 13% were Black, 23% Hispanic, 15.9% were other non-Hispanic, compared to only 5.3%. So children in communities of color were 2 to 4 times more likely to be infected with COVID-19, not necessarily symptomatic, but to be infected. And this bottom part of this slide shows the dates of specimen collection. Obviously, they, as the pandemic was spreading throughout the country, because remember, it was first Northeast and then spread to the South, to the southern states. Between September 1st to September 19th, the percent positive was 18%, but that's when the disease was certainly really at its height and its peak in the southern and middle states. Next slide, please. And then if we look at the mortality rates, again, they're lowest among children under 18 years of age. As you can see, they're 0.3, 0.4 per 100,000 population. And I have a later slide that will show you the actual numbers compared to, obviously, our older adults above 85, above 75. It really does go by age if you look at the mortality rate. So we know that's why it's important to vaccinate our seniors as soon as possible. Next slide. So we began seeing the different presentations, the clinical presentation. First, it was reported out of the United Kingdom, and remember, the COVID-19 pandemic surfaced and certainly peaked before it did in the US. So in April, last April, that the UK scientists and physicians reported that they were seeing the severe inflammatory syndrome. And first they reported it in 8 children. And of those 8 children, most of them were Afro-Caribbean and 2/3 were male. And then New York, I remember, I think I got a call from Dr. Hewlett had I seen this. And I think it was either May or June, but certainly in May, New York City started reporting cases of this severe inflammatory syndrome only in children. And again, usually under 18 years of age. And really they were more the school age children. The children under 4 and 5, the children under 5 years of age really did not present with MIS or this severe inflammatory syndrome. They had very mild symptoms. So these were school-age children and adolescents. It was very interesting that as a result of these reports, the CDC actually released an advisory, and that required that, or requested, probably required healthcare providers to report these patients so we could get a better idea nationally as to what was going on. So anyone 21 years of age, they had to fit a certain criteria, and then they would be reported to the state health department, and then those were reported to the CDC. Next slide. So this is the case definition. I'm just going to point out a few things. First, you had to be under 21 years of age. You had to show signs of inflammation. Well, fever is that hallmark sign of inflammation. Usually they had clinically severe illness requiring hospitalization. They ended up in the intensive care unit. They had to have more than two or more organ involvement. Well, what do I mean by that? Well, their kidneys might show some early kidney failure. These children came in with cardiac dysfunction. And what I mean by that is their hearts were not pumping efficiently. They showed a decreased ejection fraction, which has to do, the heart is a muscle. And when we would do an echocardiogram, we could see that that heart muscle was not pumping as efficiently. And these children were totally healthy. Some of them were athletes. So this was quite a shock to see this happening. So because the heart was not pumping efficiently, they would come in shock. And would be admitted to the intensive care unit. Many of them required medications like adrenaline, epinephrine, and so forth to raise their blood pressure because the heart was not pumping efficiently. They had hematologic. I think we've already talked about thrombosis. They were at risk for developing thrombosis. They had GI symptoms. Some of them had skin manifestations. They had these things called COVID toes, where their toes would have bluish spots on them, or be red or purple. We began seeing that as well, or neurologic. And there had to be no other diagnosis to cause these symptoms. And they had to have proof of having had SARS-CoV-2. So either there was a history that they had tested positive for SARS in the previous month or two, or if you tested at that time, they had antibodies to SARS-CoV-2, which is the virus that causes COVID-19. Next slide. So that was the official definition. Next slide, please. Now these are, you say, okay, well, what did they look like when they presented? So fever was a big part. Some of them had GI symptoms, vomiting and diarrhea. If you remember when COVID was being reported out of Wuhan, China, it was mainly a pulmonary, it was a respiratory. They had pneumonias. Yes, we see some of those pneumonias in the children as well, in the older children. But this was something different. Many of these children did not have any pneumonia or any respiratory symptoms. It was all heart-related or cardiac. They came in complaining of fatigue and weakness. They could have a rash, a generalized rash, but also that particular rash I'm talking about on their toes. Some of them did have cough and difficulty breathing. Chest pain was another symptom. Many of them had complained of body aches and fatigue. And then the other interesting thing that we've seen as part of when we started seeing MIS, this inflammatory syndrome, we started seeing an increase of appendicitis. There is some correlation here. We're not quite sure what's going on and what the virus does to the gut. But indeed, we do see an increasing number of kids with appendicitis, the younger children, even though they have no other symptoms of COVID other than appendicitis. Next slide. So again, this is a CDC slide, epidemiology slide, and this looks at the daily count of MIS cases, and it's looked at by date of onset. So, and I say this because remember, we started seeing the acute cases of pneumonia related to COVID, in January, maybe even we had our first case in December. But as you see that peak that we had in the Northeast in the spring, and then we had somewhat decrease, and then things opened up a little bit, and sure enough, the number of cases came back. But if you notice, these cases did not occur when the pneumonias were occurring. So in other words, what was happening is you were infected with COVID-19 first, and then after the infection, so we call it a post-infectious or a post-inflammatory condition. So they were not suffering from the virus itself, they were suffering from the inflammatory response to having been infected with the virus. And that's what this multi-system inflammatory syndrome is all about related to COVID. So again, now that the cases have spiked again, because this is again national data, we also saw an increase in the blip of MIS cases in children. Next slide. And this looks at the total. So it's estimated there have been through December 29th, 1,600 some odd cases of MIS that have been reported, 26 deaths. They have occurred in 47 states. That's based on the reporting. Remember I told you the younger children usually don't get sick either from the pneumonia or the inflammatory syndrome. And the average age, and these are cases of the inflammatory syndrome, was 8 years of age. And I can tell you personally, the cases we saw were definitely older school-age children, adolescents, and not children under 5 or 6 years of age. Again, 57% were male. And here again, 63% were occurring in Black and brown children. So there definitely is a predominance there. Just as in adults, there's a predominance, there's a disproportionate representation of this infection in adults as well. Next slide. This has to do, again, this is again looking at the disproportionate number of cases, but it's by adjusted incidence rate ratio. And I'm just going to refer you here to these numbers. So compared to white counterparts, and these are children with MIS, Black children are 6 times, have 6 times the incidence compared to their white counterparts. Latinx children, 4 times the incidence rate compared to their white counterparts. And Asian Pacific Islander, 3 times the incidence rate. So there definitely is a disproportionate no matter which way you look at the data. Next slide. So in summary, when we talk about COVID-19 in children, definitely under 18 years of age, they have lower rates of COVID-19, both incidence. I didn't show you hospitalization, but they're not very sick, so they don't get hospitalized, and definitely lower rates of mortality compared to adults. Children are susceptible to SARS-CoV-2, and we know that now testing, they may be asymptomatic, but they come in for other things. A child might come in for, a fracture, and we screen all the admissions for COVID-19, and we'll find some of those are infected, but they have no symptoms related to COVID at all. Younger children tend to have fewer respiratory symptoms than adults. We know that this multi-inflammatory system disease is a complication of COVID-19 infection. It occurs after the acute infection, and again, disproportionately affects children of color. We know that there are further studies that are needed to fully understand the role of children and teenagers, certainly in transmitting this infection, as well as regarding this complication of multi-systemic disease. So how do we prevent, next slide, COVID-19 infection in children? Well, up until now, we're going to do all of those public health preventions that you're told about in terms of wearing a mask and hand washing and staying at home if you're sick. But this is the rationale for doing vaccine trials in children. The burden of disease is significant. It does occur. There's a disproportionate burden among children in communities of color. We haven't even started to measure the effects to children and society with regards to their school, their education, and their development. Continued burden if we wait for the natural herd effects. We have to have greater than 90% of the population vaccinated to have herd effects, and we're nowhere near there. Vaccination, we don't know this, but maybe it's going to prevent, even if you don't have symptoms, but you get infected and you carry that virus in your nose, maybe vaccination will prevent the virus from living in the nose, so therefore those people can't go out and infect other people. So as clinical trials are starting in children above 12 years of age, and then they usually go down to the 5 and above, and then down to 2 and above. Next slide. So I'm going to end here and turn it over to our next speaker. I think it is Dr. Thomas Cujo. Am I correct? Okay. And Thomas is a former medical student of mine, so I'm very proud. Thank you for your attention.
All right. Next slide, please. Next slide. Next slide. Yep. Okay, here we go. Good morning again, or good midday. So I'll be discussing the aging considerations, as was stated previously, internal medicine and geriatrics trained. And I care for older adults across care settings, in their homes and long-term care settings, as well as inpatient settings. So hopefully that will come through in some of my remarks. Next slide. So this slide is simply to demonstrate the varied presentations of SARS-CoV-2 infection to reflect, I would say, the diversity of the host immune response to the infection. So we see here, as has been mentioned in previous presenter slides, that there can be respiratory implication, cardiovascular, gastrointestinal, neurologic, more general systemic impacts, renal and integumentary. Dr. Whitley Williams mentioned Covetose, and that's one of the manifestations that can occur in the integumentary system, as well as those that impact various systems. And I think we're increasingly understanding its manifestations. Next slide. This slide is also to demonstrate the variability in how individuals can present and be impacted by the coronavirus. We have here individuals who may be asymptomatic all the way to critical illness. And so notably, we see that we need to be screening and diagnosing individuals across the spectrum, providing so that we can ensure that we're providing the appropriate care, but also due to concerns about transmission. And so throughout the course of the illness, if individuals are asymptomatic or not, they should be in isolation. Additionally, this slide shows that the course when we are adding potential treatments, which range from antiviral therapies, antibody therapies, and anti-inflammatory therapies. You can move to the next slide. So in all of this, the considerations for or risk factors for severe COVID-19, we think about individuals who are older, individuals with chronic diseases such as COPD, cardiovascular disease, diabetes, individuals who are obese, sickle cell, chronic kidney disease, and individuals who have immunocompromised states and cancer. Next slide. And so moving closer and thinking about the impact on older adults, I think it's important to go back to our insights that from almost around this time last year, when we begin to see the transmission of the coronavirus. So I'll point out two of these reports from the MMWR. On March 18th of 2020, it was identified that the coronavirus could cause severe illness and death amongst older adults with chronic health conditions, and that the insights that we garnered from these initial transmissions from the long-term residential care facilities in Washington State was that there was a significant mortality associated with this, and that at the time there were limitations in effective infection control and prevention due to staff working in multiple facilities, which potentially contributed to intra and interfacility spread. Next slide. And so some of the implications for this was that, as some of you all know, and as I have seen, that this impacted how long-term care facilities would move forward during the pandemic. And so some of the implications for this are that it compelled these facilities to identify and exclude potentially infected staff members, to restrict visitation policies, and to ensure that there was early recognition of potentially infected patients, while also implementing the appropriate infection control measures. Next slide. The next MMWR report a few weeks later, I think demonstrated something else that was important. Essentially that there could be community transmission rapidly through some of these long-term care facilities, and that many of the impacts had not been previously described. And so in these Washington facilities, following the identification that there were cases, all residents in this specific facility were tested. And 3 of the 4 residents who had positive tests were asymptomatic. So it was important for us to say that, hey, in these congregate settings, though that people not being presenting with certain symptoms or signs, that we need to test all of them, because those who are asymptomatic could potentially transmit to other individuals. The next slide. So this, I would say, has an important implication, because it identified that symptom-based screens might not be enough to identify the coronavirus in these independent and assisted living facilities. And so suggesting that we actually need to be doing actual testing of the virus rather than just screening individuals for their symptoms. Next slide. This slide, I think, as a geriatrician, it's important to note because it impacts assisted living facilities, the numbers of long-term care facilities, and the care for older adults, just understanding the distribution of older adults. And so we can see that in the New York area, that about 16.4% of the total population is older than 65. And we know that our friends down in the warmer states in Florida have a higher percentage of older adults, and also individuals in Maine have some of the highest percentages of older adults in the country. Next slide. And then also, this has important implications in stressing the impact on older adults, in that 8 in 10 out of the deaths that we've seen from the coronavirus have been in individuals who are 65 and older. And this is pretty profound because, and it impacts us in so many ways. It impacts me in terms of losing patients, but it also impacts, I'm sure, everyone on this call in terms of losing the older adults in our family to COVID. Next slide. And then going further to stress this impact on older adults, we can see that the rates as individuals age, that as you get older, the rates are higher for hospitalizations. And then you see here in data from the CDC that individuals who are in this 85+ group have 630 times higher risk for death than the comparison group of 18 to 29-year-olds. Next slide. And so the coronavirus has impacted us in a variety of ways. And so in terms of our healthcare system, it's impacted how we've provided patient care, not only for COVID care, but also for primary care. And so this slide from the Kaiser Family Foundation basically suggests that individuals who are 65 and older, you can see 32% don't don't have a means of talking to their doctor via telemedicine, phone or computer. And then 57% may have this technology, but don't. So this is almost 90% of the people, older adults, not being able to engage with their provider through this technology. Next slide. And so this, I would say, goes directly to this slide in terms of how during this certain period last spring, where individuals who are older than 65 may have delayed care. And so because they essentially are not getting the care that they would have gotten for their diabetes, for their heart disease, for their lung disease, for their arthritis. And so essentially that, not getting care during this time does have an impact on their health. And so it's important to note this as well. Next slide. And so in all of this, I think we are seeing in some, in the media reports about how does this impact how people are receiving care and what this means. And so in this recent NPR story from just a few days back, nursing home critics say that COVID-19 immunity laws are a free pass for neglect. And so if you haven't seen this story, I think it's an interesting one because it profiles individuals who were not necessarily getting the care for non-COVID care during the time of this pandemic because of the circumstances of isolation and protocols that nursing homes were putting in place. Next slide. And then moving on to what had been touched on earlier, just thinking about the vaccine and this article in the Times, thinking about who should get the vaccine first and thinking about its implications. Next slide. And I mentioned, who should get it first, who should get it, because I think we know from this early report a few days back in the British Medical Journal about 23 deaths occurring after vaccination. And so I don't share this information to be alarmist, but to note that deciding who gets the vaccine is an important consideration and it may not be best for individuals who are frail or terminal. So I think that this goes into thinking about the risk benefit of the vaccination in certain populations. Next slide. So in summary and in conclusion, I think we have to be mindful of these important considerations of the very clinical manifestations of the coronavirus, be reminded that older adults are at the highest risk, that these congregate settings are challenged by various staff factors, various structural factors, changing protocols, and that we are navigating or have navigated some uncertainty about the best practices to address these situations. I think it's also important to note that the variability in the access to telemedicine potentially has implications for people's care, as well as the decline in non-COVID-19 care during this time. And then lastly, understanding that there's some balance and risk benefit that we need to consider whether individuals get the vaccine or not. Thank you. Or you can advance to the next slide. Thank you. And if individuals have further questions, this is my email address.
Okay, thank you, Thomas.
You're next.
I will take over from this point. And again, thank you to the sponsors. Thank you to Dylan Braverman for inviting us to put together this program. It has been very exciting. I'm going to be hard pressed to follow the first 3 acts of this program, because I'm really honored to be able to serve with such outstanding colleagues, and I've learned a lot from these presentations. So my task for the next few minutes is going to be to give you an overview on the 2 vaccines that are available, and also to give you some recent news on the vaccine that was just discussed in the news today. We go to the next slide, please. So just as background, I don't know if you know who was pictured here, but this is Dr. Jenner. Dr. Jenner was an English physician. And at the time that he was practicing, smallpox was essentially the scourge of the world, or at least of Europe. And vaccines, this was the first vaccine that was actually made available, and it was actually very, very effective. Dr. Jenner was wondering why the so-called milkmaids did not develop smallpox. And it had to do with the fact that there was another disease known as cowpox that was very, very similar genetically to smallpox, and that these milkmaids were coming in contact with this, and as a result, they developed immunity. And if we go to the next slide, we go to some further information about this. This term vaccine or vaccination is derived from variole, or smallpox of the cow. And the term was devised by Dr. Jenner to denote cowpox. And Jenner is often called the father of immunology for his work, and it's said to have saved more lives than the work of any other human, if you think about that. And as we said, in Jenner's time, smallpox killed around 10% of the population, with the number as high as 20% in towns and villages where infection spread more easily. We go to the next slide, please. Now, these are some of the common vaccine preventable diseases, just to take you back a bit. And you see the list here, including polio, pertussis, measles, mumps. We call these out because if we go to the next slide, the question that we ask is, what happens when we stop vaccinating? So right now we're vaccinating to try to stop a pandemic. But a few years ago, maybe over the last 10 to 15 years, we were dealing with a situation where people decided they no longer wanted to use the vaccinations that were around. When I was in medical school in Wisconsin, the professors told me, they said, look, you're probably never going to see a case of measles. You're going to never see a case of the mumps, because we've eradicated all of those infections because people give their kids the vaccinations. And so we're not going to see that anymore. Well, guess what? In around the year 2010, we started to see all of these things again. And in April 2019, more than 285 cases of measles were reported in New York since October of that year. And nearly all were associated with people who lived in areas like Williamsburg or Borough Park, Brooklyn. In California, 2010, over 9,000 cases of the whooping cough, and 10 infant deaths were the result of that, the highest rate in over 60 years in that year. And that was because people decided they didn't want to vaccinate. In Rockland County, New York, mumps outbreaks, and there had to be an executive order which had to be enacted, and there were 6,000 unvaccinated children out of the schools. Nearly 17,000 doses of measles, mumps, rubella were given in a 26-week period. So this is all data from the CDC publications, and this demonstrates very, very clearly what happens when we stop vaccinating. If we go to the next slide. Now, how do the COVID-19 vaccines prevent infection? We know that there are macrophages, and macrophages are white blood cells that essentially swallow up or digest the viral particles and the dead or dying cells. The macrophages leave behind parts of the invading germs or viral particles that are called antigens. The body identifies antigens as dangerous, and it stimulates antibodies to attack them. And the B lymphocytes are defensive white blood cells, and they produce antibodies that attack the pieces of the virus that are left behind by the macrophages. So we have macrophages, we have B lymphocytes, and then we have T lymphocytes. And the T lymphocytes are another type of defensive white cell. They attack cells in the body that have already been infected. So if we go to the next slide, we then know that the vaccines help our bodies develop immunity to the virus, and there are different types of vaccines that are going to be working in a different way in terms of offering protection. With all of the types of viruses, the body is left with a supply of what we call memory T lymphocytes, as well as B lymphocytes that will remember how to fight with that virus in the future. Now, it takes a few weeks for the body to produce T lymphocytes and B lymphocytes after vaccination. Therefore, it is possible that a person could be infected with the virus that causes COVID-19 just before or just after vaccination, and then get sick because the vaccine did not have enough time to provide protection. Now, sometimes after vaccination, the process of building immunity can actually cause symptoms such as fever. And a lot of this we place under the broad term reactogenicity. These symptoms are normal and are actually a favorable sign that the body is building immunity. So a lot of the things that you see described associated with the vaccines, these systemic reactions that are more likely to occur after the second shot than after the first shot, are actually in many ways a good thing. Go to the next slide, please. Now, currently, there are three main types of COVID vaccines that have either completed clinical development or soon will be completing large-scale phase 3 clinical trials. We have the mRNA vaccines, and those two that are available currently are the one from the Moderna company and the one from Pfizer. We have viral vector vaccines. One of them is from the AstraZeneca company, and then the one that we heard about this morning, and I think we do have a slide talking about that, from the Johnson & Johnson Janssen vaccine division. And then we also have what we call protein subunit vaccines, and these are the traditional types of vaccines. In fact, some of the pneumonia vaccines are protein subunit vaccines. If we go to the next slide. So the mRNA vaccines. These vaccines contain material from the virus that causes COVID-19 that gives our cells the instructions on how to make a harmless protein that is unique to the virus, and this is referred to as the spike protein. You've probably all heard about the spike protein. This is where how the virus attaches to our cells. And after our cells make copies of the protein, they destroy the genetic material from the vaccine. It's been stated that this occurs over a period of a few hours. Our bodies recognize that the protein should not be there, and it will build T lymphocytes and B lymphocytes that will remember in the future how to fight the virus if it comes invading. The next slide, please. And this is just a cartoon that actually shows us what happens. One of the things to keep in mind for skeptics that say, well, you know, this was really rushed along. Well, back in January of last year, we actually had the complete genomic sequencing of this virus. So scientists generated an mRNA sequence that codes for the virus spike protein. The RNA sequence is a blueprint for making the spike and its swath or contained within a lipid coating for delivery. Once it arrives, cells read the information in the mRNA sequence to produce millions of copies of the spike protein, and the protein fragments spur the immune system to produce antibodies that can then protect when a real virus enters the cell. We go to the next slide, please. And so we have two important components here, the antibody component and the T lymphocyte or memory component. Now, this was, I believe, from the Pfizer protocol, study, but I believe that the Moderna was very, very close to this. And the vaccine efficacy did not differ among subgroups of age, sex, race, ethnicity, whether a person was obese or not, and also coexisting conditions. And just jumping to some of the bottom lines here, when they actually did this study, they compared placebo individuals who received placebo versus those who received the actual vaccine. And when we looked at cases of COVID after the first dose, there were 82 in the placebo group and 39 in the vaccine group, which gave us an efficacy of 52% after a single dose. After 2 doses, that went up to 95%. And this was the secondary endpoint was infection in those without prior SARS-CoV-2, and additional approximately 1,700 in each group were looked at for efficacy. And this efficacy is very similar between these two mRNA vaccines. I think it's listed as between 94 and 95% for both the Pfizer and the Moderna vaccines. If we go to the next slide. Next slide. Okay. Next. Okay. If we can back up, I think that. No, keep going. I'm sorry. Okay. Here we are. Good. So one of the things that we, of course, want to know as well, when we talk about efficacy, we also want to know about safety. And they looked at reactions within 7 days. Now, I didn't mention the important fact that in both the Pfizer and the Moderna trials, there were between roughly 40,000 people that were enrolled in these trials globally. And for the Pfizer trial, they were from 16 years of age and older. For the Moderna trial, it was 18 years of age and older. And again, the safety profile for both of these is very, very similar. So injection site pain was probably the most common, and I'll testify to that. But what I will say is that the pain after the first or the second dose for me was really no greater than what I've experienced with the flu shots, which I take every year. There was fatigue, things like fatigue and headache and fever. These were things that did occur in some individuals. What we know from discussions with the manufacturers and with the clinical team is that these were very short-lived. And there were some things like appendicitis and Bell's palsy. I should also mention here, and it's not on the slide, and we'll talk about this in a bit more detail, there were some anaphylactic reactions that occurred. And just to put it into perspective for you, it's not on this slide, but for the first roughly 2 million doses of these mRNA vaccines, there have been about 23 cases of anaphylaxis, no deaths, and all of those individuals who had the anaphylactic reactions recovered uneventfully. Most of them did not even have to spend the night in the hospital. The next slide, please. So the viral vector vaccines, there are 2 candidates that are in late phase development. The AstraZeneca, Oxford University candidate, and then the Janssen division of Johnson & Johnson vaccine. The viral vector vaccines contain a weakened version of a live virus, a different virus than the one that causes COVID-19. For the AstraZeneca product, it's what we call a simian virus, which is a virus that can cause a mild infection in monkeys. And for the Johnson & Johnson Janssen product, it's an adenovirus, which is a virus that can cause mild infections, usually in humans. Once the viral vector is inside of our cells, the genetic material gives cell instructions to make a protein that is unique to the virus that causes COVID-19. And this is the spike protein that we talked about earlier. Using these instructions, the cells make copies of the protein. This prompts our body to build T lymphocytes and B lymphocytes that will remember again how to fight the infection. We go to the next slide. Now here is the slide that we just made this morning, which is very exciting. Reference on CNN, which was on just this morning. So the Johnson & Johnson, there was a readout of their phase 3 clinical trials, and we'll see more about this as we move forward. They had planned an enrollment of up to 60,000 individuals globally. And as we said, they use an adenovirus vector. They reported 85% efficacy versus severe disease. And I think as we look at this data, it's very important to put it into perspective. We don't necessarily have to look at, let's say, this 66% overall efficacy, although that's important, and I'm not going to negate that. But can this virus prevent severe disease? And that's where you have this 85% efficacy versus severe disease, 72% efficacy versus moderate and severe disease, and then 66% overall. Now, what are the potential advantages? Dr. Fauci gave a interview, I believe it was probably just this morning, and he talked about some of the advantages here. And we need as many candidates as we can get out there in the community. This is an inexpensive preparation, so it's less expensive to make than the mRNA preparations. This is going to be a single dose, and so this might be more adaptable to some of our low resource settings in other parts of the world, as well as here in the United States. There's no cold chain requirement. So you'll recall back in December when we heard the reports from Pfizer about requiring very, very low temperatures to maintain the proper storage. We don't have that with this preparation. And then this is a very important area. No anaphylactic cases were reported during the clinical trial. So that's really very important. It was believed that the polyethylene glycol that is present in both of the mRNA vaccines, that may have been responsible for the type 1 hypersensitivity or anaphylactic reactions. And so there is no polyethylene glycol in this product. Go to the next slide. So this is exciting, and let's try our best to keep up with that. Now, the protein subunit vaccines include harmless pieces of protein, proteins of the virus that cause COVID-19 instead of the entire virus. And once vaccinated, our immune system recognizes that proteins don't belong to the body. And if we are ever infected in the future, the memory cells will recognize and fight the virus. We go to the next slide. And so if we track what's been going on right now, there have been over 82.5 million doses of vaccines administered. That's a combination of the Pfizer and the Moderna. 59 countries globally, an average of 3.95 million doses per day. A total of 25 million doses in the US have been administered. And across the US, this is about 7.8 doses per 100 persons. 54% of the doses have been delivered to states, doses delivered to states have been administered. If we go to the next slide, please. And you, of course, are very interested in knowing about the virus variants, and I'm sure we'll have time for some questions about this. But the South African variant, you heard earlier this week, there were 2 cases in adults that were diagnosed in the state of South Carolina. And this variant has been identified in 30 countries throughout the world. There's concern about this because it's felt that the virus is probably, the vaccines may be less active when we have infection with this variant. Some European countries do extensive testing to detect the variants, and unfortunately, our capabilities here in the United States have been hampered because of a lot of the budget cuts which occurred in our to our budgets as far as the CDC and other agencies that are responsible for that. There's also a UK variant. At least 315 cases have been identified in the US from 28 states. A Brazil variant, cases identified in a traveler returning to Minnesota from South America. And then the South African and Brazil variants may be less susceptible to antibody. So there's a lot that we'll have to learn about these as we move forward. These viral variants are more easily transmitted. And there's actually been some discussion about whether there might be benefit for using 2 masks or using thicker masks or layered masks. We'll have to stay tuned for that. The next slide, please. And I think at this point, I want to thank you for your attention, and I'm going to turn it over to Dylan Braverman for the Q&A. Thank you very much.
Thanks, Val. You know, keep it on without mute just for a second, because Keisha, if you don't mind, could you go to slide 65? Because Val created 8 myths concerning the vaccine and has some comments on that. And I think that I'd like to kind of jump to that, and we have 15 minutes. I know that we're running a little short on time, but I'd like to just talk through the myths. I think that they're really informative, and the type of things that a lot of our audience might be able to dispel amongst the patient population.
Sure. And maybe we can all join in answering some of these.
All right. So myth number 1, which is it's slide number 65, Keisha. I'll read it out loud.
It's on the other. It's on the other deck. It's keep.
Sorry about that.
Keep going.
Luckily, we're not a radio show because we have a lot of dead air. I apologize, everybody. We'll get there in 1 second. This is my fault because I called an audible.
Yep. And you're no Tom Brady.
No, in many ways. There we go.
Okay. So one of them, do you want me to read through it, or are you going to read through it?
You know, you could do it. I mean, I would just read the myth, but you could just go ahead and jump with it.
Okay. Myth number 1 is, and we hear this a lot, we can't trust COVID-19 vaccines because the development was rushed. And this we know is false because work on these viruses began way back in 2003 with SARS-1. And it continued with what we call Middle Eastern respiratory syndrome in 2012. And we knew the genomic sequence a year ago. And there was a lot of funding that went into this. There was a full FDA review and a full review by the Advisory Committee on Immunization Practices. Sorry for that typo. And full review by task forces from various states, including New York State, California, and also the task force which Dr. Whitley Williams and I sit on with the National Medical Association. So we feel pretty comfortable that this was, although it occurred quickly, that there were not shortcuts and that there are not safety or effectiveness issues. Myth number 2, the vaccine will give me COVID-19. The vaccines do not contain live coronavirus. There is no risk of causing disease in the vaccinated person. The mRNA vaccines contain a harmless piece of what we call the spike protein, as we discussed. And the spike protein is found on the surface of the coronaviruses. So we're not giving people live vaccine. Next slide. We don't know what's in these vaccines. Well, I joke with a lot of people about this because a lot of the medications that we take, we don't know what's in the medication, but we know that the medications help us. The content of the vaccines, however, are clearly stated. When we look at the information that has been provided by the manufacturers, we know exactly what's in the vaccines. And standard labeling is a requirement by the FDA and other regulatory agencies around the world. Next slide. Myth 4, these vaccines will alter my DNA. Well, that's not true. We know that the messenger RNA material is rapidly degraded. The mRNA and the COVID vaccines, it's rapidly clear. It's not the same as DNA. The mRNA from the vaccine cannot combine with our DNA to change genetic codes. Myth number 5, we go to the next. I already had COVID-19, so I won't benefit from the vaccine. Well, that's false. The COVID vaccines are recommended for persons who have previously recovered from COVID. And it's recommended that ideally individuals who have had COVID should wait for about 90 days after recovery. And that's because our natural immunity is going to cover us for at least that period of time, possibly longer. However, the measured immune responses following the vaccines are up to 4 times or even higher the response seen following natural infection. Next slide. Since COVID-19 survival rate is so high, I don't really need a vaccine. Well, this is really false as well. Although the survival rate from COVID is 98%, between 10% and up to 40%, depending upon age, of impacted persons will develop long-term symptomatology, the long haulers as we call them, where we will have symptoms that will go on for several weeks or even months. Long-term complications can be very debilitating. At the health department, we've heard of numerous reports of people having myocardial infarctions or heart attacks, pulmonary emboli, and just anecdotally, during the height of the pandemic back in the spring, I was on daily calls with the medical examiner who was doing COVID testing on people that died for unexplained reasons. And when those COVID tests were positive, he was finding that some of these patients had findings consistent with acute infarctions, acute pulmonary embolic disease. Complications such as coagulation disorders place the recovered persons at risk for these things, including strokes. And of course, recently, erectile dysfunction has been reported. Next slide. And myth number 7, COVID vaccines cause sterility. This is something that has been a frequent question for us at the health department among some of our young women who are coming in, who work in healthcare. And this myth was perpetuated on the internet. It was claimed that the vaccine spike protein cross-reacts with another protein, syncytin, that is important to placental formation. And the COVID vaccines do not contain this protein. The vaccine spike protein is very different from syncytin. And for that reason, there's absolutely no evidence that there's going to be a cross-reactivity. Next slide. And myth number 8, now that we have vaccines, and the pandemic will be over very soon. The pandemic is not going to be over until we reach herd immunity of about 80%. And so we have to continue to wear our masks. We have to continue to do distancing. We have to continue to avoid large gatherings until we are hitting that 80% range, especially with the new strains. And I think there may be one more before I turn it back over. Okay. Turn it back over to Dylan.
So we do have some questions, and I think we have plenty of time to get through them. So the first question we have is, in light of a recent studies that confirm that pulse oximeters are less reliable in African Americans, I'm wondering what healthcare providers may be doing differently with pulse oximetry measurements in this patient population during the pandemic. Does anyone have any insight or something they want to jump into that?
Yeah, that's a good question. I think there was a recent study within the past year at University of Michigan that they were testing ICU patients with COVID and finding that there was a bit of a discrepancy in the pulse ox versus when they get an ABG level from their arterial blood gas. And so it's important in the African American community that number one, these folks who are really sick, that we're making sure we're using not only the pulse ox, but also other tests such as ABG, and frequently checking those things to make sure that they're getting the supplemental oxygen. And then making sure that those who are discharging don't necessarily need oxygen, that they have good close follow-up, because they can go home and potentially, we don't know yet because those studies aren't there, but if that pulse ox machine they're using at home is given a slightly incorrect reading, we just want to make sure that if they're having any other symptoms, they're able to quickly get the care they need.
Thank you. There was a question asked and answered, and I just want to say it out loud because I think it's an important piece of clinical information for folks to know. There was a question in MIS C, how long after COVID infection should we expect to see the symptoms? And Dr. Whitley Williams answered, usually within 2 to 4 weeks after infection or after someone else in the household is having an infection. So I just wanted to say that because I think that's something that a lot of us I frankly was curious about. So I thought that was a great answer. Next question. This one is for Dr. Kudo. We have seen a tremendous loss in the elderly population. What significant changes have been made for long-term care facilities?
Yeah, so in terms of changes that have been made, I think there's much more to do is what I would say. We know long-term care facilities have been kind of caught in the crosshairs of the coronavirus pandemic, and we've known, I think, that policies need to be developed, funding needs to be appropriated or provided, and regulatory systems need to be revamped to ensure that our long-term care settings are meeting the needs of older individuals and all other individuals who are using these care facilities. And so I would say that I think the coronavirus pandemic has led us to wake up about these issues. And I think the verdict is still out in terms of what will be the sustained changes. We, of course, have seen changes in staffing, changes in how, what staff, maybe how we screen staff before they come in. In my own work, every time I go into a long-term care facility to work on a weekly basis, I get screened for the coronavirus. So we'll see how that translates to other things. We also know that the infrastructure for these testing has to be thought, because we're experiencing this now, but hopefully we have the systems in place if there is a pandemic in the future.
That was a great question. I think we could have a whole presentation on that, and you answered it very well and very succinctly. Next question. This is from another one of our members. I think it's a myth that African Americans don't want all of the information published. I think the question is, I'm just going to paraphrase that is it a myth that African Americans do not want the vaccine, and how to address that situation? And I'll kind of add to, because there's a second question, I'll morph them both into the same one, is that how do we make sure that the underserved communities have access to the vaccine? It's been a problem with them getting access. Obviously, the statistics bear it out, to the COVID testing, the antibody testing, and the treatment. And we want to make sure that they have access to the vaccine. So I know a few of you may want to address this, so I'll go ahead and open it up.
I can mention a couple of things, and then I think Dr. Whitley Williams, based on some of the work she's done with the advisory board, can mention some things also. With regard to accessibility, we are desperately trying to set up what we call pop-up sites. That is our health department. We're setting up sites in various places in the community, so we'll be more accessible for people that have transportation challenges and people that have internet challenges as well. And it's not a myth as far as vaccine hesitancy, and I think Dr. Whitley Williams can comment a bit more on that, because we've all spent a lot of time looking at that data. You have to unmute yourself.
Yeah, thank you. Yes, thank you very much for that question. I reiterate that there have to be sites for vaccination in communities of color. And I think the second thing is, with regards to surveys, I know my foundation did a survey, and it was maybe about half of people who identified as being Black or African American said that they were not so much were against getting the vaccine, but more they were not going to get it at that time. They wanted to wait and see. So based on not just the mistrust from the history, and Tuskegee is always put up as the model example of why Black folks in the, from all, from any background are really hesitant. But I think the education and information is the key. The second thing is we worked with our providers, our African-American physicians who primarily, if they're in practice, are taking care of people of color. And their patients were coming up to them asking them, would you take the vaccine? Well, it became, we became aware that some of the African-American physicians did not trust the vaccine, again, because of lack of information. And what the National Medical Association has done, which is a provider organization of mostly African-American physicians, was to put on seminars and workshops and disseminate information about the vaccines and about clinical trials and what percent of people of color who have participated in those clinical trials. And we are beginning to see a shift in that more and more people from communities of color really do want to get the vaccine, but they don't have access. And this goes back to lack of resources for the infrastructure to set up places where people can get vaccinated. So whether it's at retail pharmacies, you know, the CVS or Walgreens, I probably shouldn't mention retail names, but pharmacies. And then if there is the new vaccine, if it is approved, it's one, it doesn't have to be refrigerated, it's one dose. You know, perhaps we can look at group practices or private practices participating in administering the vaccination because there are many physicians of color who want to do that for their patients. I think with the Pfizer, it was a little bit difficult because of the requirements of freezing the vaccine. Many did not have the appropriate equipment. So I hope that answers your question.
Thank you. I'm going to try to squeeze a few more in, and thanks everyone for their patience. Another question, how long is a person immune after the second dose of the vaccination?
Oh, that's a good one.
I don't think we have an answer for that yet. And we are going to have to look at this sort of sequentially. One of the other big questions that we have right now is whether we're going to actually require additional boosters to cover these variants. So that we don't have an answer for that question, but we'll just have to sort of observe and see what does happen.
Yeah, I was gonna add, I think in the Moderna vaccine, they were able to test for antibodies at least up until 90 days after the second shot. And so we know that there is still immunity, but what happens on day 91, we're not quite sure yet. And so to be determined.
The next question, are there clinical factors that can help differentiate between the different strains of the virus?
Not that we're aware of. I think that there was a lot of concern about whether the new variants might actually cause disease that was more severe. And I don't believe that there are any clinical characteristics that will allow us to distinguish whether someone is infected with the standard strain or the wild strain versus these new strains.
The next question, and it's kind of a compound. What could be done to ensure that nobody skips the line for the vaccine? And what could be done to make sure that the patients follow up for the second dose in 3 weeks?
That's a difficult one because we are on an honor system, and the fact that people would have to provide letters from their physicians or documentation they're on certain medications, we felt that those would be barriers to people being vaccinated. And as you know, the current administration wants to vaccinate 100 million people or give out 100 million doses, administer 100 million doses within the first 100 days of the new administration. So unfortunately, people have tried and I guess have jumped the line. But for the most part, we really have tried to follow a prioritization, immunizing those at risk first, paid and unpaid healthcare workers, long-term care facilities, not only residents, but the staff who take care of them. Essential workers, people who, first responders, public safety officers, people who drive the buses, who provide, work in food processing plants, et cetera. So in answer to your question, it is very difficult to so-called police that. The goal is to get as many people immunized as possible. Hopefully, people who really need it can have access. It's very difficult to enforce that rule unless we have people provide written documentation, and that would just, I think, create further barriers.
Okay, I think this one is for everybody, and the question is well, what are you doing in your practice to try to push the high-risk patients to get the vaccine, if anything, and how do you chart that?
Yeah, I can take that one. I think that this all goes back into the importance of doctor and patient relationships. I think individuals having access to primary care is critical, and I think this example exposes that. Many people who are, may not have full understanding of coronavirus and the impact of the vaccine may need to have one-on-one conversations with their providers to convince them. So I think that opening portals for people to have an opportunity to ask these questions to their providers, but also where we've all seen in terms of the numerous platforms that have been opened up so that people can hear from different experts about their perspectives on the vaccine. And I think even here today, we've had the opportunity to go through some of those myths and concerns. And I think hopefully the further dissemination of these things will allow people to have more understanding and be more comfortable so that when it's their time to get the vaccine, that they're ready.
Okay, and I think we have time for one more question, and it is, with widespread infection rates in the community going forward, should COVID-19 be on the differential as far as complications in year 2, 3, 5 going forward?
Yeah, definitely. You, as Dr. Hewlett mentioned in his slides, there is a big focus on deaths with COVID, but people have long-term complications from it. There are many patients who are in long-term acute care facilities who are trached and pegged. We talked about pulmonary embolism, strokes, heart attacks, and things of that nature, which are all complications. And so when someone does come in and we know they have a previous history of COVID, that definitely broadens our differential, and we're going to think about some other things too when we're trying to figure out what brings them into the emergency department.
Thank you. Just one more, then I'll let everyone say their goodbyes. As far as the vaccine, is there any contraindication for pregnant patients?
I can answer that. There was guidance that was published within the last few weeks from the American College of Obstetrics and Gynecology. And they basically said if a woman is in a high-risk kind of a setting, for example, if we have a pregnant woman who works in an emergency room or in the critical care unit or in a clinic or in another setting in which she might be at high risk, let's say some other occupation, it is not a contraindication and that she should have a discussion with her physician. But they do not believe that the administration of the vaccine is going to cause anything untoward for the unborn child. But they do mention one caveat, and that caveat is that we do not have data to back up this recommendation. So this is guidance. However, this is how they feel about it. And the reason for the importance of this is that there have been some serious complications that have occurred, and I think even some maternal deaths that have been reported among women who have developed COVID during their pregnancy. And so that's one of the reasons why one has to look carefully at the benefits of the vaccine versus the risks.
Thank you, Dr. Hewlett. With that, I think we've overstepped our time a little bit. It's been an absolute pleasure working with everyone and getting prepared for this presentation. And I can't say enough about the time and effort that everyone's put into it. So thank you very much. I'll turn it back to Keisha, put myself on mute. And thank you all for listening.
Thank you.
Yes, I'd like to thank our panelists for sharing this timely information with all of our members and colleagues who are on the program today. So with that, I wish everyone a very nice day and remain safe.
Thank you.
Thank you for the invitation. Bye,
Thank
everyone.
you. Bye.
Bye-bye.